Welcome to the webinar. This is presenting the new HLH pathway convened by GERFT. I'd like to say this is GERFT's first pathway that concerns a rare disease, so a high complexity, low volume disease. And it's been contributed to by a huge range of people to whom we're very grateful, from a number of different specialties and right across the age range. So the webinar is being recorded. Recording will be available to people later, as will the questions and answers. We will be able to share the slides later. If anybody wants to ask any questions during the course of the webinar, please put them into the Q&A. We will deal with as many of those as we can at the end, and we'll be able to follow through on many of the others afterwards. So welcome to the webinar. We have a video for you of patient stories. We're really grateful to these patients for having recorded their stories and allowing us to share them. This is a slightly edited version, and so we will be able to share with you the link to see the full version.
So my name's Pamela. I am 42 years old and I was diagnosed with HLH last year, 2022. My baby was delivered by emergency C-section in June, and I stayed in recovery for, I think, a little bit longer because they couldn't bring the blood pressure down. And then I was transferred to maternal care unit, I think that's what it's called. But the fever started to become much more frequent. And I could now tell exactly, I could pinpoint exactly when it was going to start. It felt as if there was this gush of cold air that would blow every time it was starting. I was told that you're going to UCLH and, you know, they have the specialist service there and they're going to help you. So in my mind, I need to get to UCLH. And it's like every minute on the clock, I have a 7-year-old and a newborn. And before I was intubated, my fear is, are they going to have a mum? Your life is in the hands of people who you don't know, who are trying to figure out this rare thing that has happened. And I remember I was told that there's this rare thing called HLH, and someone came and sat with me to discuss it. Every consultant, I felt that they wanted to make things better. I felt that. I felt that they, you know, whether rare or not, I felt that they had, it's almost like a personal interest to make sure they did everything they could. And what I also liked is they were honest when they didn't know. But I liked the honesty and I liked the transparency. And I liked that there was multidisciplinary approach to this.
I wasn't keeping well. I was having some stomach ache and fever on and off. And is when that I was admitted to King George Hospital on 16th of May 2022. I was put on ventilator, but I was not improving at all. And doctors were kind of quite perplexed in terms of what has happened, and they were trying to really diagnose with many tests. Dr. Jessica Manson was contacted with a suspicion that this could be HLH. And that's where the turning point happened. And very carefully, very carefully, I was moved all the way from Queen's Hospital to UCLH in the middle of the night, I believe. Besides the love and affection that UCLH has offered me, I remember faintly and vaguely I was under the ventilator. I didn't know what is happening around me. My wife was being assured, told, informed the next steps, what is happening. That meant a lot to me. Not only that, when I was feeling a little better, every day there was somebody or the other used to come and cheer me up. just to bring that smile back.
I now belong to an HLH fundraising and a support group to make it more awareness of HLH. I went to a meeting with this support group and spoke to a couple of the parents who said, "Tell us your story." They all knew each other. I gushed about how wonderful it was, how Ezra was doing so great, how I can't praise the team enough, and how I know that this treatment, these little injections that we came home with, have saved his life. I then listened to their stories after they'd asked me all the questions, and out of 6 lots of parents, I was the only parent with a surviving child. That's not okay. HLH is something that can be cured, something that can be fixed, and something that you shouldn't lose your children. I know that we're probably in the minority because there has to be so much more awareness, and I don't think that a lot of doctors know about this. So the doctors that we're friends with, that we've told Ezra's story, they're like, "Wow, we've never heard of that, we don't know what it is." So I know that a lot of people don't know what it is, and if we can do anything to spread the word and to make this something that is automatically checked for when people have got these symptoms, then it will change so many people's lives. And anything we can do to change people's lives and save people's lives is worth it. And I cannot praise Rachel and her team enough.
So welcome back, everyone. My name's Peter Lanyon. I'm a rheumatologist in Nottingham and co-lead the Rheumatology Girth programme. And as we've heard, HLH affects people of all ages, from all demographic backgrounds, and in any specialty, the presentation of suspected HLH can be non-specific, often mimicking sepsis. And although considered a rare disease, it's likely to be underdiagnosed, and the incidence is increasing, as shown on the next slide, please. So this is a slide of a publication by colleagues Joe West and Mark Bishton, who's a member of the Pathway Group in Nottingham, in collaboration with the National Disease Registration Service in NHS England, and it highlights the need and opportunity for a girthed HLH pathway. This study of all cases of HLH in England, well, we're just trying to get the slides up for you, showed that amongst all cases diagnosed between 2003 and 2018, using electronic health data from hospital admissions and death certification data, the incidence rate quadrupled, with inflammatory disease associated with HLH increasing more amongst younger people, whereas in older age groups, the largest increase was seen with hematological malignancy associated HLH. The crude 1-year survival in this study was only 50%, and this varied considerably by age and gender, being worse in men, and by the associated comorbidity, which highlights the importance of recognition, of identifying the trigger, and of cross-specialty collaboration, as shown in the next slide. And from this study of the 1-year survival probability following the diagnosis of HLH, by associated comorbidity, the stark message here that you can see that most of the deaths from the slope of this chart are in the first 2 months, highlighting the time critical nature of intervention. The 1-year survival varied by comorbidity, being best in the green line, so HLH associated with rheumatological or inflammatory diseases at about 70%, but much worse with HLH associated with hematological malignancy in blue at just over 25%. And so in this study, hematological malignancies complicated by HLH had the most dismal outcomes regardless of disease subtype, as did anyone over the age of 55 regardless of comorbidity. And the other important message is shown in the next slide, please, that the survival outcome, sorry, can we go back to the previous slide? The survival outcome remains static during the study period. And so whatever our geography and specialty here today or watching later, we all have a responsibility and an opportunity to try and do something about this. And this is why GIRFT has brought together this cross-specialty group, including haematology, rheumatology, infectious diseases, immunology, microbiology, general medicine, obstetric and fetal medicine, critical care, pharmacy, commissioning, and others, to produce this pathway to support the care of suspected HLH in any setting. And throughout our work in this pathway, we've been inspired by some of the pioneering work already being done in this area, underpinned by the principle that we're going to take the best of the NHS to the rest of the NHS, and particularly work done by all of our next speakers in this webinar. And it's a pleasure to firstly introduce Rachel Tattersall and Jessica Manson, who will talk us through the details of the pathway.
Thanks, Peter. I'm Rachel Tattersall. I'm an adolescent and adult rheumatologist in Sheffield. Next slide, please. We are assuming in this, by dialing into this webinar, that you have an interest in HLH and at least some basic working knowledge of this condition. So we're not going to talk about clinical presentations and so on. We're going to try and help all of us who have to think about HLH in a clinical scenario to embed good working practices and use GIRFT to lever those good working practices. The questions that underpin the way in which the GIRFT pathway has been devised are the questions that all of us have to deal with. Could the person in front of me have HLH? How am I going to make a diagnosis? How am I going to get support for investigating, treating this patient? And how do I make sure I do the best I possibly can? Next slide, please. The pathway is shown in this link here, and on the next slide, if you're more technologically competent than me, then it's possible to use the QR code, but the diagram is reproduced here. You can see that the flow chart follows essentially a patient and physician, I would argue, journey, but there are three parallel concerns for us as healthcare teams looking after patients, and we have to assess our patient's presentation. Is this person at risk of, or could they have HLH? How am I going to confirm the diagnosis? And then how do we test for the underlying driver and treat? And the key thing here is that although the pathway goes in a kind of linear progression, these three domains have to be considered in parallel, and that's where the MDT working comes in. And the beautiful thing about this diagram online is you can click on the various hyperlinks going through to the supporting information, and we hope this is a really useful resource therefore. Next slide, please. I'm going to talk through the first two columns, the presentation and the diagnosis, and the question is always, when should we consider HLH as being something that the person in front of us has? Is there clinical evidence of hyperinflammation? And there was a lot of debate about what should go in the very first box of the pathway, but what we're trying to capture is that anybody who is significantly unwell, particularly if you don't have a diagnosis, or if you have a diagnosis and the patient isn't responding to treatment, who might have a sepsis-like syndrome and who has a persistent fever, is at risk of HLH. What we need to do is to think about the 3 Fs, and this is a useful way of using readily available biomarkers, so fever, falling blood counts, that's the hemophagocytic bit of this illness, and ferritin. And one of the things that I hope the GIRFT pathway, for example, might help services to do is ensure that a ferritin, which is a really good biomarker, cheap and easy to do, can be turned around within a few hours in your hospital and titrated to a level such that it can be used sequentially as a biomarker. Once you've identified your patient could be at risk of HLH, we don't have an evidence base for clinical criteria for definitive diagnosis. We have probability scores. The most widely applicable score is the H score, predominantly for adults with HLH. But if you click through on the hyperlink, you can see more applicable disease scores for smaller groups like children with systemic JIA, for example. Next slide, please. In some ways, if you've identified the patient, if we think that this patient has HLH and we calculate a score and it's really high, in a sense, you're home and dry. It's HLH, you're onto that third column, finding a driver and treating. I think it's more difficult, and I have really struggled with this, and this is where our multidisciplinary team comes in. If you think the patient could have HLH and the score doesn't quite hit a threshold, if the overwhelming view of us and our MDT clinicians, or our mate who also knows about HLH, is this probably is get on and treat. But the scores can be repeated, recalculated day on day, and you often see the score rising, and then that hits a threshold for making a secure diagnosis. And how we get advice depends entirely on local context, and the rest of this presentation will show you some of the different ways in which we can work together and how GIRF can help us to embed those pathways. But the bottom line here is HLH requires a group or an MDT approach, and if you're the only person in your institution who thinks the patient might have HLH or knows what HLH is, please make use of our National Advisory Panel. It runs weekly, 50% of the time chaired out of Sheffield, 50% of the time chaired out of UCLH, and details are can be found through the GIRF pathway. And with that, I'm going to hand over to my colleague, Jessica Manson.
Thanks, Rachel. Next slide, please. So my job is to take you through the what do we do next stages. So you've established now that this unwell patient in front of you has HLH, and the next really important question is just how unwell are they? And importantly, where should they most safely be managed? So we have now a very low threshold for critical care, and our critical care colleagues who now have lots of experience of managing HLH completely get the importance of this and the safety of the environment that they work in and how that can help us manage patients. In parallel with that, and the trouble with managing HLH is you do have to get rather good at doing several things at the same time. So you want to start some treatment, which I'm going to come on to in a moment, and then investigations. So you've recognised this patient probably has HLH with the 3 Fs, so fever, ferreting, falling blood counts, and then you want to send off the baseline tests that allow you to confirm that diagnosis using an H score. So that is some baseline biochemistry and haematology tests and cross-sectional imaging. And then at the same time, start that question, why has this happened? So HLH is always the upshot of something else. So you need to start investigating this glorified pyrexia of unknown origin, the cause of it, while you start the treatment. So one of the questions we're often asked is how quickly should we do these things? So as soon as you've thought, could this be HLH, it's really important that you get those initial things sent off for the H score within really the next 4 to 12 hours, because we know that patients can become very unwell very quickly. In the subsequent day or two, you want to start investigating for the most common causes of HLH, hematological malignancies, some investigations, and rheumatological diseases. Excuse me. And then if that doesn't give you an answer, over the next days and couple of weeks, you'll be starting to do the more sophisticated tests. Next slide, please. So what do we mean by first-line investigations? So these are the things that are readily available in almost all of the secondary care institutions that we work in. We chose them between multiple specialties because we think the evidence would suggest that these are the best tests that allow you to identify A, HLH itself, B, the organ effects of HLH on the patient that you're managing, and C, to begin to screen for the most common causes. So you'll see there's cross-sectional imaging. Some hospitals have PET scans, some don't. In children, often we use ultrasound rather than X-ray imaging anyway. You'll see that there's various baseline virology and other microbiology tests, and then some rheumatological stuff, which will be relevant to almost all patients. Next slide, please. So second line investigations are when we start to think about things that may be slightly less common depending on where you work. So I don't see that much malaria, but it is relevant for some people who've been recently travelling, for instance. And then there are particular tests in a patient who might present with HLH who has immunocompromise before they get to us. So either people post-transplant or people with known HIV with that's not well controlled. And then you might also want to start thinking about some more definitive tests for malignancy, and we've grown to understand the importance of biopsying any abnormal tissue to look for malignancy, and this will be guided by the imaging that you've done. And then we've also become aware of how dangerous neurological involvement of HLH can be. So in this sort of second line, we'd also advocate starting to say, well, if the patient has any neurological signs, we'd start getting towards an MRI and considering a lumbar puncture thereafter. Next slide, please. specialist or third line investigations are ones that you might discuss with somebody if you're not used to managing HLH before you request them. For us, soluble CD25 cytokine testing is not available in the hospital that I work in, so I have to send it off somewhere else. And you might, we're quite often asked through our National Advisory Panel, you know, in whom should we be doing these tests, and we can discuss that. Next slide, please. So you're starting to work up the extent of organ involvement that you have from the HLH and the possible causes, but this is a time when you actually have to start treatment before you have all the answers. So I think now we all agree that if you meet the criteria for HLH and you're convinced of that enough that that's the clinical picture, then you should start treatment immediately, and almost always that's with widely available inexpensive corticosteroids. And if you're a rheumatologist, you typically reach for methylprednisolone. If you're a haematologist, you often reach for dexamethasone. It really doesn't matter, but you need to get something going. Next slide, please. So second line treatment, one of the great things that NHS England has done for those of us working in England is provide universal access for anakinra for HLH patients, all comers, wherever you work, whichever institution, you're allowed to give it, you're encouraged to give it, and your pharmacy should be refunded for it. If you Google NHS England and anakinra, there's a nice document that tells you how to do all those things. But you shouldn't wait for approval, you should start treatment, and often in practice what we do is start anakinra at the same time as corticosteroids. It's quite hard to know exactly how much anakinra you should give. In the UK, we go up to 8 milligrams per kilogram on the current guidance. In America, they commonly use higher doses. Often paediatricians use higher doses than adult physicians. Our current practice is to start at about 2 milligrams per kilogram twice a day intravenously. Next slide, please. Third line treatment. Thank you very much. Typically, we would do following discussion between colleagues from multiple specialties. So one of the purposes of allowing access to anakinra was to reduce the use of intravenous immunoglobulin, which is a scarce resource, and the data behind using it in HLH is not excellent, though we do still continue to use it in some people. We also use cyclosporin, and then obviously I'm a rheumatologist, not a haematologist, so I'd never actually prescribe etoposide, but we do use etoposide and have learned that actually sometimes using etoposide quite early in a patient's illness is critical to outcome. Next slide, please. So I'm now going to hand over to my colleague Stella, a haematology consultant in Croydon. Just before I do so, I want to give a massive shout out, please, to Polly Hyde for all her amazing work creating this pathway. Thank you.
Thank you very much, Jessica. I'm Stella Kotsiopoulos, I'm a consultant hematologist at Croydon. I will be speaking about embedding a HLH pathway at Croydon Health Services, together with my colleague, Dr. Sarah Levy, consultant rheumatologist. Next slide, please. So just to give a general picture about Croydon Health Services NHS Trust, this is a 670-bed busy district general hospital. We started collaborating to establish the pathway first in 2020. So collaboration started between rheumatology and hematology specialists, and the aim was to identify and tackle challenges in early recognition and improve outcomes in HLH patients. Collaboration widened quickly with participation of ITU, pharmacy and laboratory teams. And also we established close links with the HIHASC and the National HLH MDT, which were most helpful and supportive in our efforts. The establishment of a HLH protocol and pathway at Croydon led to improved recognition, management and outcomes for our patients, which we will demonstrate in the next slides. Right, so you can see, you can access the pathway in the link, and also, next slide please, the flow chart that Dr. Tattersall also presented in the link. Next slide please. Right, so our efforts started with case reviews. particularly with cases that did not develop as we'd want to, but also looking into what led to successful management in some cases. Reviews were done jointly with ITU pharmacy and laboratory teams, and that was pivotal in establishing an MDT approach. So we identified challenges in the following 4 domains. First of all, lack of recognition of symptoms and signs of HLH by non-specialist teams. And this is critical because most often patients present to non-specialist teams, and early recognition, as we know, is critical in successful management. Teams also did not recognize that these patients can deteriorate rapidly. And there was also a delay in ferritin result review. When it comes to investigations, the H-score was not routinely used for highlighting suspected cases and for diagnosis and monitoring. And tests used for calculating the H-score were not part of the routine workup, and often some tests were missing, and that compromised H-score calculation. When it comes to treatment initiation, teams often waited for driver identification to start treatment, and that introduced delays. When it came to drug management, anakinra was not kept in stock. Specialized funding was not there, and the processes were very time-consuming for reimbursement of costs. And reimbursement of costs made, I suppose, introduce further reluctance in accessing this treatment early. And then etoposide was not available out of hours. And we've all tackled challenging cases, and being not able to access third-line treatment out of hours can impact outcomes negatively. When it came to ward management, the precedence was that ITU beds were allocated to people in need of organ support, and we all recognize that once organ failure develops, we are already very late in our patient pathway, and we wanted to establish a more proactive rather than a reactive approach to management. There was incomplete understanding of markers of impending arrest in HLH, which include mild hypertension and persistent tachycardia. Next slide, please. So the following interventions were made in collaboration with rheumatology, hematology, laboratory, clinical biochemistry, and pharmacy. So when it came to engagement, we established link with the HIHASC and the National HLH MDT. We brought cases to the MDT, we discussed and received valuable support and guidance. And through practice rather than theoretical guideline development, we established an MDT collaboration and management with participation and communication between rheumatology, hematology, ITU specialists, the pharmacists, and the laboratory specialists. And then we widened that team collaboration to include acute medicine specialists who are often at the front line of recognizing and managing these patients. We moved on to education, where we used case debriefs, educational presentation, and grand round presentations to raise awareness to the wider trust. And we also included junior doctors through teaching, sharing of pathways, and podcasts. We adjusted our processes for test requesting and reporting to speed up recognition and diagnosis. And also we improved drug availability and reimbursement process to try and eliminate all potential factors causing delays in treatment initiation. And we also try to continuously improve our patient management through ongoing learning for new and rotating teams, and also by reviewing of outcomes of our cases and updating and adjusting our protocols. So we make sure that this is a dynamic and not a static process. Next slide, please. So what have we achieved through these outcomes? So interventions did lead to improvements in the 4 domains I previously presented on. So when it came to recognition, there is increased awareness now among general internal medicine and acute medicine teams. There is an ITU escalation pathway based on the H score. So once we hit that 169 score, then it is far easier and straightforward for our patients to be transferred to HDU and ITU for further management. And we've established a 24/7 laboratory process of feeding back high ferritin results, both from hospital and community. So results are called back to the requesting team and the on-call hematologist to ensure these are acted on. When it comes to investigations, we've embedded use of the H score in the pathway, and all the tests in the H score are now part of an order set. So with the click of a single button, we request and we have results for all the necessary tests to calculate a complete H score. And teams are now aware that they need to start treatment at the point of suspicion and diagnosis and not wait for results from investigations to come back, which may often take many days. When it comes to drug management, anakinra is now in stock. We have access to it in and out of hours. There is a working agreement with the regional hub for reimbursement, and there is proactive identification of patients in need for IV etoposide in agreement with pharmacists. And these patients are flagged up to our pharmacists earlier in the week, so there is time to prepare IV etoposide if need be. Now, we all recognize that there will be some cases where the question comes for use of etoposide out of hours. To tackle that, we have included in our protocol an oral to IV etoposide equivalent dosing table to use if need be out of hours. We hope we never have to, but in case we do, it is there. And finally, when it comes to ward management, all our suspected cases with H scores more than 169 are being taken care of in ITU or HDU for enhanced surveillance and support. And there is a recognition by teams that HLH requires intensive management and monitoring. And there is a proactive flagging up of suspected cases. So the internal medicine team now come to us with queries whether cases are of pyrexia of unknown origin, for example, could fulfill diagnostic criteria with HLH. And that has certainly been the case with the latest 2 cases we've had over the summer. I will hand over now to my colleague, Dr. Sarah Levy, consultant rheumatologist, to present on some data on outcomes. Thank you. Sarah.
Next slide, please. And these are just 2 slides to tell you how it's going. So just to put this into some sort of context for you, we have a population of about 390,000 in Croydon. And you can just see the cases that we treated for HLH with anakinra in the year since 2020. Our pathway was actually only really rolled out in 2023, but our knowledge has increased since 2020. And I think you can see it's not all that rare. In 2023, we treated 7, and thankfully 6 of those survived, and only 1 unfortunately died. In 2024, we've already had 4, of which 3 have survived and 1 sadly died. And I do know Stella was managing 2 cases on the same medical ward at the same time. So you need to bear in mind this may not be as rare as we think. Next slide, please. And this is just in terms of the burden on the lab. We had 88 cases in Croydon of a ferritin over 3,000 in a 14-month period, of which 6 of those cases had HLH. Of those, 4 patients recovered. 2, they had an infectious driver, 1 had a hematological malignancy, and only 1 actually had a connective tissue disorder. And as a result of our work, I think the whole of Croydon now perceives HLH as an urgent, non-specialist and probably not very rare condition. Next slide, please. And I'm passing over to Matt.
Hello. Good afternoon. Thank you for the opportunity to present. My name is Matt. I'm a consultant in acute medicine and rheumatology, currently working in Maidstone and Tunbridge Wells NHS Trust. But I'm really presenting for on behalf of the Cancer Medway HLH network. Next slide, please. Just a quick disclosure of interest. Next slide, please. So in the context of, so in this presentation, I'm going to take you through the structure of our Cancer Medway HLH MDT. And just for some context, there isn't a single well-recognized university tertiary hospital in Cancer Medway. We are collections of, I guess, what we know as what we all see as DGHs. None of us have all the specialists in one place, and therefore we have gone for a network model of collaborations, and we cover quite a big geographical area, just under 2 million populations, consisting of 4 acute trusts. And just for context, our MDT is usually chaired by one of my colleagues in Margate Hospital, which is about 1.5 hour drive away from where I work. So it's quite a vast geographical area, which brings its own challenges, which explains some of the structures that we have gone for. Next slide, please. So we established our MDT in around February 2023. Before that, there were a few interested individuals such as myself who probably occupies that positions where I'm one of the few people in the hospital who have heard of as interested in HLH, and I used to collaborate quite closely with the national MDT either at UCLH or Sheffield. We have essentially very much plagiarized and then edited the performer from the UCLH MDT referral. And we currently accept referral from any clinicians, both from laboratory-based and clinical specialties. We are very proud of our very responsive service. By the work of a very effective admin team, we have been able to call an online MDT typically within 1 working days of the referral getting sent, and the benefit of that will be clear as I continue my presentations. In terms of our governance structures, we have received, my colleagues, Dr. Delord and Margate, has really done all the legworks there, but we have at least 6 monthly clinical governance meeting, and we submit our data to NHS England, who is supportive in a way that we definitely got it. We definitely got our medicine costs and management sorted in that every one of the acute trusts is able to recharge NHS England for the drug costs directly. Next slide, please. So this is the list of my co-conspirator, at least the main people involved in the Cancer Medway HLH. Using this slide just to illustrate the specialties that are involved in our MDT, and also a shout out to all the work done by my colleagues here. Without the key names on this slide, our MDT would not happen, and I would not be speaking to you here today. So thank you for everyone on this slide. I think one of the key takeaway points from this slide is that while you can have an MDT, it is also vitally important to actually engage the team that's currently looking after the patients. We don't have dedicated ID or rheumatology beds in our DGHs, so patient generally stays under their admitting general medicine teams. Having them involved in the MDT and making them feel like they are part of the MDT is vitally important to drive the management of the patients. Next slide, please. Going on to what we have achieved in MDT, and these are data from my local hospital in Maidstone and Tunbridge Wells. So before our MDT was established, you can see that our mortality rate was really running quite high. It was running at about 75% in the 28 days mortality. Since the MDT has started, we're able to bring our mortality down to around 50% mark, which is very much what the figures reported in major tertiary centers. So a huge, real tangible benefits here. Next slide, please. And this slide illustrates our time to access, and we use anakinra as our proxy for measuring our promptness to access treatment. So as you can see from these individual dots, before the MDT, it was taking about 12 days from admissions before the patient had get their first dose of anakinra. And since establishing MDT, the average is now 5.5 days. So once again, the MDT is facilitating more prompt and facilitating more accessible and prompt treatment for our patient populations, which we feel is probably one of the key drivers in improving our mortality outcomes. Thank you. Next slide, please. Working as a regions also means that we have a more consistent and a stronger voice when it comes to the reconfiguration of other services. So we're able to feed into our regional laboratory service reconfigurations. And so across Kent and Medway, we now have we either now have or is going to in the next few months have a consistent tax flag or any ferritins over 2,999, so over 3,000. And the wording is as such with a link to the H-score calculator, and anyone with a ferritin over 9,999, the aim is to have a phone call to the referring team or to the on-call team of ours. As exactly which on-call team it should be, that's still a bit of work in progress because of the number of different trusts involved. But the in-hours phone calls has very much been agreed. Next slide, please. We also engage very much in education outreach work to get other specialists more engaged in HLH and to recognize HLH. So I will have the pleasure of presenting in the Society of Acute Medicine conference in October. My colleague, Dr. Delord, has presented in our regional hematology network meeting. And I think all of us in this MDT has presented at various grand rounds and clinical governance sessions to spread the words of HLH far and wide. Next slide, please. So I've also worked together with my colleagues, Dr. Smith, who have a special interest in simulation scenario. So we have written a HLH-related simulation scenario for senior registrars in general and acute medicines. And on the right of your screen here is just a bit of qualitative feedback. So when they are asked what is the 3 things that they learned from it, nearly universally, the HLH scenario was seen as a key learning point, and it's something that's very well received through our simulation exercise. Next slide, please. So just the final slide to take away. The HLH MDT is not possible without the commitment and dedications of my colleagues. People have dialed into the virtual MDT all over the place, including from one of our hematologists dialing in from a resort in Thailand. That is dedications. Most of us have some recognitions in our job plans over time, but most of us are still doing it out of our own goodwill. It is, however, one of the most rewarding and educational bits of my job. Having the admin team behind the MDT is vital, as important, if not more important, than the clinicians involved, really. And one of the unintended benefits from COVID-19, I guess, is because we are much more familiar with web-based MDTs and seminars like this now, so it makes our MDT a lot more efficient. And over time, I think we are able to win other clinical team overs. We are not just people who order lots of investigations and not get involved in the patient's management. We do give practical advice that, as my colleagues have said earlier in this webinars, that it makes people feel that they are able to do their best for the patient in front of them, and we find that other clinic teams do get engaged and they do come on board eventually. So it has not always been easy. It hasn't always been smooth, but once you get going, I think you'll find a group of like-minded individuals who is willing to go along this journey with you. And I think that brings to the end of my section of presentations. I will now hand back to Peter for the Q&A. Thank you.
Thanks very much, Matt, and to all of our speakers, and thank you to all the questions we've had so far in the chat, many of which we've been answering as we'll go along. But there's 2 questions I want to just also discuss in a bit more detail because they're very relevant to this aspect of in any trust, which team should take the lead or take the ownership or be driving the management of people with suspected HLH. And as you've seen from the questions in the chat, this is very dependent on your local setting. The idea of the pathway is it should be setting agnostic, and you should be able to adopt this to use in any trust. But Jess, is there anything you want to add to that in terms of that question about which team should look after, how's the best way to structure that care, in addition to the great talks we've heard already?
Yeah, thanks, Peter. So I think I'd say that between us, we have colleagues through the advisory panels and through our national group, HLH, who've sort of made this work in a number of different settings. So I think if you are looking to start thinking about the structures in your organisation, we can probably match you with somebody who's done something quite similar in their own trust. So Rachel and I've, worked together for a very long time, but actually have really quite different structures in the way that the patients are cared for in-house. And what we do at UCLH has also evolved over time. So what we're trying to do with that bit of advice, as with every other bit of the pathway, is say, here are some things that you need. Please take them into your institution and make them work for you. And between us, we've had quite a lot of experience. Please reach out and we'll try and help you make it work where you are.
Brilliant. Thanks, Jess. And thanks also for that offer of help through the great work of HLH, and the link to that group is also in the chat. The second sort of, generic, really important question, and thanks to our colleagues in King's for raising this. Jen has said, are we happy for steroids and anakinra to be commenced by, acute medical teams following the pathway? Because there may be a delay in, an MDT or haematology expertise may not be available on site at that time. Rachel, could I ask you to talk a little bit more about this question?
Yeah, it's such a good question. I think I understand that, because what you're asking, I think in simple terms, is it reasonable to start what's relatively potent immune suppression without the immune suppression specialist stood at the end of the bed? I always go back to the example of pneumococcal meningitis, where you not only treat with antibiotics, but you give very significant amounts of dexamethasone alongside that, because we recognise that infection and inflammation trigger each other. So I think the precedent for treating inflammation with potent immune suppression is that it saves lives, almost regardless of the situation. So if the clinical question is there sufficient hyperinflammation that I think the patient either has full-blown classical HLH or is on the pathway, then you aren't going to do any harm by giving that intravenous methylprednisolone or high-dose dexamethasone and or anakinra overnight, and then discussing in whatever your local pathway is at that time. And in fact, following the logic, you may save a life. And I have a number of cases now where, for example, somebody came in with what turned out to be primary CMV infection. They came into A&E Resus really, really unwell. We have like MAT and autoferritin flag. The clinician was phoned at midnight. They did the H score. This is an ST3 in acute medicine on the medical admissions ward. They gave IV methylprednisolone, and this man who'd been teed up to go to critical care, by the time I saw him at about 10 o'clock in the morning, was saying, when can I go home? Work's really busy and I can't afford to be off. And I know that sounds a bit too good to be true, but it is actually true. And so I think I would, in the constraints that we've given, in that really clear, does the person have HLH or hyperinflammation? Can I convince myself that's definitely the most likely thing? And am I happy that giving the treatment is safe? Then treatment should be started. I hope that answers the question reasonably.
Thanks, Rachel. That's beautifully clear, and I think highlights the links back in to, as you said, working through the pathway and the timings within it. Rachel, could I also bring you back to the additional question about anakinra, because you've mentioned use of anakinra. We have a question here about, is it kept in stock in local pharmacies? What's the reimbursement? That I know you've partially answered. We have answered in the chat. Is there anything that you want to add to that around the anakinra stock aspects from your discussions with the NHS England specialist commissioning pharmacy teams?
So I led the proposal and the policy, and we did it very much from a real world. This could be any clinician in any hospital asking for anakinra. high cost, actually anakinra is quite cheap in the short term, but high cost drugs like anakinra are refunded to clinical teams via this BlueTech system. And if you're able to get your pharmacist to look at the anakinra BlueTech form, you'll see it's really clinical. It says, have you definitely think this is HLH? Have you had some kind of multidisciplinary discussion? Which score have you used? And will you just use 7 to 10 days of anakinra in the first instance and then review the patient? The critical thing is to get your pharmacy team to draw down that BlueTech form to your institution. And sometimes I've discovered across the country there are local arrangements about these drugs where a central service has to okay before the BlueTech form can be completed, but that is a local arrangement and not in the spirit or in fact what is written in the anakinra policy. So the bottom line is there are sometimes some funding issues, but they're usually local patterns which can be unpicked. And I am meeting with NHS England in October to discuss exactly the issue which one of our colleagues has put in the chat about. There's real nervousness about holding these drugs that might not be used and what happens if they go out of date, and can we be a bit smarter about the hub and spoke arrangement. But I and many colleagues on the call have been in the position of putting anakinra in a taxi. You know, it isn't actually a very expensive drug. It's £40 per 100 milligrams, so it's cheap. It's much cheaper than admitting the patient to ITU. And if you haven't got it in stock, I bet a hospital within a taxi ride has got it and can release you at least enough to get you started. So I think there's quite a pragmatic approach. So the bottom line is any hospital which has specialised rheumatology service, which I can't think of a DGH or hospital setting or children's hospital that doesn't fulfil those criteria, can draw down the BlueTech form. There may be some local difficulties of that, which can usually be unpicked, and I frequently get emails about it. I'm happy to have those emails. And we're hoping that maybe we can resolve this at a more national level, as I say, opening those discussions with NHS England in the next few weeks.
Thanks very much, Rachel, and thanks for all the questions coming through in the chat. We'll try and get through as many as we can. Coming back, Matt, perhaps to your talk about the issue of the biomarker and the ferritin and the flags for calling through a raised ferritin, and the question is a question about cutoff and what should that be for the lab to ring about raised ferritin. Matt, do you want to answer this one?
So we pick a cutoff of above 9,999. So in practice, anything that reaches a 5 figures ferritin, that's partly to manage the workload of the laboratory staff. So we look at how many phone calls that's going to be in one hospital, and that comes up to about less than 20 phone calls per year, and that was deemed to be acceptable. Also, that seems to be the figures that's being used by other major institutions. So we have picked a cutoff for that for 9999. I know associated with that question on the chat is whether ferritin should be routinely added to the order set for patients with sepsis. And the honest answer to that is that we have had multiple discussions about this, both within HIHAS, within the GERF pathway groups, and many other settings. We don't, and I think the honest answer is that we don't have a consensus about that. We do all agree that if you are thinking that this patient may have HLH, you should have a very low threshold of asking the lab to do a ferritin, and we encourage all lab to set up in a way that can generate a ferritin result accurately within a few hours. But whether that should be a routine, whether that should be a new lactate, I think is something that might emerge as a consensus in the next few months or years. So sorry that that's a bit of a circular answer to the questions.
No, that's really helpful. Thanks, Matt. And we've also had a question around, related to that, around the fact that because anakinra might be seen as a rheumatology drug, does that make the ownership of the patient within rheumatology? Is it then less difficult to get further investigations done? And we highlighted at the beginning that although this is a pathway that was, in some ways led by rheumatology, that's because we didn't have necessarily a GERF work stream for all of the specialties involved in this care. But in terms of that question Stella and Sarah, I wonder if you might want to put something in the chat around how teams may benefit from greater collaboration between haematology, oncology and rheumatology based on your expertise of how you've done that. We've had a question about the epidemiology, and is it genuinely increasing, or is this greater recognition? So in the study we mentioned earlier, that quadrupling was essentially a year-on-year increase, so it's unlikely to be solely influenced by either changes in coding. It may be greater recognition, but the interesting thing about this data was the two groups with the greatest increase seems to be, younger people with underlying inflammatory disease and more elderly people with HLH associated with hematological malignancy. And it's possible, one of the suggestions is that increase in HLH in younger people with inflammatory disease might be the increased use of biologic drugs and might be the increased use of drugs in people who are EBV naive as a subsequent trigger. But it's a good question. We've got another question coming, which is really around differentiation between sepsis and HLH and how difficult that can be. And we've been asked for some top tips. Can I bring perhaps you back to this, Jessica, this question around sepsis or HLH, any top tips? And it's linked to that is another question saying, we often see high ferritin, the H score is non-specific, many patients score high without really having HLH, but it's those patients that we want to be keeping a close eye on. Jess, can I bring you in for this question?
Yeah, sure. Second one first. So everything is in clinical context, isn't it? Of course, the H score is not a diagnostic test for HLH. There isn't one. That's the trouble. So you do the H score in the context of a patient where you think that the bits of the H score you're adding up are due to a hyperinflammatory process. And it is really hard sometimes. So, big differentials that we've come across or overlaps include anything where you have a significant liver hit, which puts your ferritin up, and then you have a fever and you think, oh gosh, is this a patient with, ischemic liver and then a secondary infection, or does it all add up together to be one thing, which is HLH? Matt and I were having a very similar conversation to this not long ago in the heat of the moment with a patient on his critical care unit. So all the things we do are done in the context of our instinct and what we think the driver of each of these abnormal tests is. So I think it's just very important to think about what the other causes might be and to work out what you think the likelihood of those are. What I'm beginning to realise is, number one, over 90% of patients referred to our national advisory panel from other teams do in fact have HLH. So I think people are pretty good at working it out when it's relevant. HLH is relevant when it isn't. And number two, that both my haematology colleagues and my infection colleagues and my critical care colleagues say, well, even if you're wrong, if you've just given 1 gram of methylpred, you can always just stop and start again, think again. And then the other thing we do is we just keep going back. So if we're uncomfortable and we think, gosh, could it be, is it, I'm not quite sure, we might repeat the ferritin even later that day, but certainly the following day. So it isn't a perfect test. We get that. It's in the clinical context. So one of the great overlap/mimic/questions is does this patient actually have severe sepsis? There isn't a simple answer to that question either, I'm afraid. But probably between 3 and 5% of patients with kind of straightforward sepsis do have a hyperinflammatory phenotype of sepsis, some of which will meet the criteria for full-blown HLH, some of them won't. And I think that people who look after sepsis all the time get good at telling the difference between sepsis and then something that's a bit more than that. Peter, and I just refer back to that previous point about the fact that you probably can't do, you definitely do a lot of harm giving somebody prednisolone 30 milligrams for 2 weeks and not thinking again, but probably 1 gram of methylpred while you have a think is not going to do much harm, if any. I'm just conscious we're slightly running out of time. Shall I hand back to you, Peter?
Thanks, Jessica. And we've reminded of one last question for a quick answer that Rachel, I might ask you to comment on the question around fever and HLH that you've highlighted.
Thank you very much for putting it in, and I just can only say how sorry I am to hear why you're asking that. We don't discount HLH if fever isn't present, and that's why we have the 3 Fs and often 2 out of 3 is good enough to put up the H score. So although HLH without fever is not common, we do make a point in the GIRFT document that it can occur, and also not to be put off in case the patient's had fever lowering mechanisms like drugs, or if they've got particular manoeuvres on intensive care. I just wanted to make sure we'd address that question. I didn't want to leave it hanging. Thank you very much.
Thanks very much, Rachel. We're out of time at the moment, so what we're going to do is close shortly. We will try and answer all the additional questions that have come in online. I'd like to thank everyone for joining us, for putting the questions into the chat. I'd particularly like to thank our speakers, our organisers, Polly and the rest of the GIRFT Pathway team, and in particular all the members of the working group that put this pathway together. Many of us are with us today. I know we've had a question about audit and impact, and in fact there will be opportunities potentially using the routine national data that I showed you earlier to see in fact in the future what's been the impact of this pathway. So we hope we've provided you with some useful resource wherever your setting is to think about how you might approach somebody with suspected HLH. Do contact us if there's further questions, and we'll try and we will produce a document in terms of the answers to all these questions. Sophie, can I hand back to you? Is there anything else that you want to say before we close?
No, Peter, that's great. Thank you very much. Just
great. Thanks everyone for joining us.